Hello. Good morning, Sue. Let's talk about target weight ranges.
Yes, please.
This is, probably, the most difficult and intangible part of recovery. Without weight normalization, to a point where a patient can achieve optimum function, there will not be a recovery. It is essential, but it is only part of recovery. There are equally important factors to be addressed alongside weight restoration, or the patient may well relapse. Talking about a target weight can give a patient the opportunity to try to negotiate their target weight, rather than focus on the bigger picture of a life without an eating disorder.
Is weight restoration, a BMI of 18.5, the World Health Organization, minimum, healthy weight?
Sue, that is minimum healthy body mass index is, indeed, 18.5. However, 18.5 BMI is not a recovery indicator. There are very few people who are healthy at that BMI level, say a marathon runner. The average healthy BMI range of the majority of the population is between the index of 21 and 25. However, there is no point just aiming for a BMI of 21 and maintaining if there are no improvements in the other eating disorder symptoms. Some eating disorder patients need their BMI at a minimum of 24 to prevent relapse.
So you are saying that the BMI figure of 18.5 is not a recovery indicator?
Exactly, Sue. BMI is not an accurate measure, as the ranges contain both false positives and false negatives. Giving an exact number BM as a target is nonsense, really. Each patient is different and requires a different weight to recover optimum function. This focus on BMI has distracted clinicians from the real process of recovery. Weight restoration is only part of recovery. BMI is, at best, a population screen. It is just a number, Sue, and quite meaningless. You are aiming for a state of mental and physical health.
So BMI is not an accurate way of calculating a patient's recovery. We should be aiming for a state, not a weight.
Yes, Sue. Mental health recovery is not tangible or easily measurable.
Could you please explain what you mean by optimum function?
When a patient reaches an optimum weight, an individual weight, where the body and brain are together, healing and functioning, the eating disorder symptoms begin to loosen, and it is as if the patient is coming out of a fog. More of their original personality emerges, and more of the symptoms of their illness disappear. It is a very individualized process, and is difficult to define in clinical terms. A patient can be seen moving forward into a life free from their eating disorder.
Right. But how do we help patients to achieve this optimum function weight?
Some patients have had their height and weight has been plotted on a percentile chart at yearly intervals. You can aim to return that patient to the percentile they were on 2 years prior to the onset of an eating disorder. Whether they are now overweight, as they are BED patients, or underweight from either bulimia or anorexia.
Right. This is not common in the UK, is it?
No, Sue. Most people do not have these. Good, but not perfect, information can be obtained from the family about what height and weight the patient was before the eating disorder. You might also want to look at the whole family, grandparents, cousins, to see what shape and size the patient might be, including all the anomalies, as there can be a huge variety of shapes and sizes. A family may say that the patient used to be just like Uncle Jack or my mother. Looking at photographs of family groups can be very helpful.
Right. Getting a picture of the wider family's physical appearances and discussing the patient's former shape and size with the family could help a lot with determining the shape and size of the patient for recovery purposes.
Exactly. There are a number of other signs that an eating disordered patient is in remission. State, not weight. This state is the normalization of heart rate, blood pressure, temperature, menstruation, growth in height, using the Tanner stage, and a normalization of social behaviors. It means a healthy interest in life outside of the eating disorder. A lot of clinicians, parents and carers have noticed that mental symptoms increase exponentially just before weight normalization, and then ease, either gradually or dramatically, after getting there and staying there. This is an indication that weight and treatment need to increase. They do not need to be stepped down because of the eating disorder's anxiety. This is a crucial point in treatment and must be worked through to ensure full remission.
Right. You have talked a lot about normal social behavior. What do you mean by that?
Normal social behavior is probably easier to define for the younger and early intervention patients. It would mean getting back to school, participating happily in classwork, engaging with friends, joining in food-related social activities without anxiety, taking up old interests and new ones, being more carefree, making new friends, enjoying normal activities with their peers.
Right. Settling into a life that does not revolve around their eating disorder, you mean?
Exactly. This is also true for older and longer-term patients. However, if a patient has had an eating disorder for a number of years, it is difficult for them to return to a life that may no longer be there. An eating disorder can mean that a patient has lost their job, their friends, their family, and has no social life to speak of. It is very hard for them to return to normal social life, as it has been a long time since they were involved in normal social behavior. This is why early intervention and structured management of remission is so much more successful. It is also why it is important to be aware of patients who have a history of eating disorders. They may have been discharged, but relapse is common, and they may require the medical risk assessment when presenting with a different illness.
So determining a target weight needs to be done alongside other medical tests, such as heart rate, pulse, blood pressure measurements, and normalizing social behavior.
Absolutely right, Sue. There is no magic formula for returning a patient back to a healthy mental state. If there was, it would make managing an eating disorder an easier job. Recovery is about a number of factors. You should remember, weight alone does not define recovery. There are many things that can help. Loving, calm, kind support from the family. CBT, DBT, many psychotherapies have all proved helpful to some. Lack of blame and guilt, teaching the patient to live without their eating disorder, helping them with their anxiety, and treating any other comorbid conditions.
Right. So I should stop trying to tailor the patient to the protocols, but rather tailor the protocols to the patient. The ultimate aim is mental and physical health, not a number.
You've got it, Sue. The goal is to see the whole person recover, physically and mentally. It takes a long time, and is hard work. If you tailor the treatment to the patient carefully, and persist with that care through the anxiety and the other difficulties, you will be rewarded with a mentally and physically healthy patient.
Thank you. Next time, can we discuss food and calories?
Of course we can, Sue.